Welcome to this webinar of the World Federation of Public Health Associations. And my name is Michael Moore. I'm the chair of the Global Task Force on Immunisation Policy, and I'm a past president of the World Federation of Public Health Associations. And it's my privilege to chair the meeting this morning, this afternoon, this evening, depending where you are in the world. For us, we are now going to look at protecting the health workforce in low and middle income countries through vaccination. And we have a number of speakers who are eminently qualified to do this. Dr. Dominic Kondji is a founding member and president of the Cameroon Public Health Association. Professor Sharmeen Yasmin is professor and head of the Department of Community Medicine at Bangladesh Medical College in Dhaka. And Dr. Joshua Egbedamami, he is at the moment in the Illinois Department of Public Health and in the oral health section, but he has been working and will talk about the challenges within Nigeria. So we have a really interesting discussion, and the way we're going to operate this evening is each of our speakers is going to give about 10-minute presentation to give an overview of the way they see these challenges. And then we'll go to a series of questions. And those questions are over to you if you're an attendee. And we're very happy to find those for you to put those within the system. And I will then reflect on those questions. And of course, I have some questions myself. So I'd like to begin by introducing Dr. Joshua Egbedamami, and he's a graduate of the College of Medicine in the University of Ibadan in Nigeria. And he was, as a student, he was a recipient of a number of several meritorious academic recognitions and scholarship awards, including the Federal Government of Nigeria Meritorious Scholarship in Academics for 2016. His interest research includes outbreak preparedness, healthcare surveillance systems, universal health coverage, and he's particularly keen on dealing with disparity in health and health equity and promoting good health and well-being in Africa. Joshua, it's my pleasure to introduce you and ask you to begin with your presentation.
Thank you very much, Michael. I appreciate the opportunity to talk about this very important topic that pertains to the health workforce in low-income countries and low-middle-income countries, and the opportunity to give the Nigerian perspective. I will be sharing my presentation. All right. I don't know, can we all see my screen?
We can, and if you'd like to go to slideshow, that would be even better.
All right.
Thank you, Joshua.
Yeah, you're welcome. All right, I will be going through this outline in the course of my discussion. And now, the healthcare workforce in Nigeria is a dynamic one, and the cadres range from doctors, nurses, pharmacists, and then we have the group of people that don't have in-depth medical training, the administrative staffs, the community health extension workers, the traditional bed attendants, and then there are the other groups that are often forgotten, which are the students in training. We have the medical students in training, the nursing students in training, and other students in other allied health profession who would eventually become the future healthcare workers in the country. Now, these are high-risk groups that are recommended to be targeted for routine vaccination by WHO. Now, looking at the vaccination trend in Nigeria, over the years, childhood vaccination has received a lot of attention, and this is so because of the increasing burden of under 5 mortality in Nigeria, mostly due to vaccine preventable diseases. On the other hand, we have the healthcare workers in which there are no major policy or infrastructure, particularly for this group of people. And as such, what entails or what is on ground is basically the mirror image of the national vaccination policy for the general population. Now, it is important that we understand the population dynamics of Nigeria healthcare workers. Now, according to a report in 2020, there are about 405,000 healthcare workers in the country. A similar report by the Nigerian Medical Association in 2021 gave a report of the number of registered medical doctors prior to COVID-19 to be 75,000. And during and after the COVID-19 pandemic, the number reduced to 42,000. Now, it's very important that we are familiar with these figures because, first of all, knowing this number, we are able to know how much healthcare workers, how many healthcare workers in Nigeria would require vaccination. And then on the other hand, we saw that prior to COVID, the number of doctors were 75,000, and during and after the COVID, the number reduced significantly to 42,000. Now, this puts the doctor-patient ratio to 1 in 22,000 in rural areas and 1 in 12,000 in urban areas, which is less than the recommended 1 in 600 by the WHO. Now, this disparity or this number actually make us understand the human resource challenge that is in play in the healthcare system in Nigeria. And this in turn increases the risk of healthcare workers to vaccine preventable diseases. Now, in Nigeria, the National Primary Healthcare Development Agency is responsible for vaccination. It is a parastatal under the Federal Ministry of Health. And here is an organogram to just show the structure of the National Primary Healthcare Development Agency. And here is the picture showing the national immunization schedule that is currently on ground for childhood vaccination. And this is an image showing the expanded program for immunization schedule in Nigeria. Also, this is the recommended vaccines for, these are the recommended vaccines for healthcare workers in Nigeria. And it's very key that we are familiar with these recommended vaccines. Now, what are the barriers in play in routine vaccination of healthcare workers in Nigeria? Top on the list is vaccine cost. Most of the recommended vaccines for healthcare workers in Nigeria are not free or covered by insurance. Now, in Nigeria, the minimum wage of an average Nigeria is 20,000. And from the study by Nigeria Bureau of Statistics, it was shown that less than 15% of households spend their income on healthcare. So 15% of the minimum wage, which is 20,000, is 3,000. And putting it in a better context, that's $6. That's how much an average Nigerian spend on healthcare. Now, if these vaccines are not free, we can imagine if an healthcare worker is to pay out of pocket, and vaccination is considered a preventative service, do we think that he or she is going to spend that amount of money on just vaccination alone? And then there are other aspects of healthcare services he or she may want to avail himself to. So another barrier is low risk perception. A study in 2017 by Ogudele et al. Identified that healthcare workers who have practiced longer have increased risk perception, and they are more likely to take vaccine. Now, this brings to mind a particular story I remember vividly. I was in a theater, and the professor was operating on a patient with comorbid condition. The patient actually has hepatitis B virus infection. And then there was this medical student who was assisting in the surgery. And in the course of the operation, there was actually a blood splash, and it went directly into the eye of the medical student. After the emergency measures were taken, the professor now uttered a statement and said, "Thank God you have been vaccinated against hepatitis B virus infection. At least that would offer some protection." And then the medical students replied that, "No, I've not been vaccinated." It was a shock to the professor, because he assumed that there should be a provision for vaccination of medical students. And this was the reality. And this is the reality on ground. Most medical schools in Nigeria, for either medical doctors and medical students in training, nursing students in training, or other allied health profession, there are no standard or standardized provision for vaccination available in these medical schools. And this corroborates with the finding of this study, which shows that years of practice is associated with perceived risk. And most of these medical students might be ignorant of the need to actually be vaccinated. Now, level of education is another barrier to routine vaccination of healthcare workers in Nigeria. And earlier, I was listing the cadres, the dynamics of the cadres of healthcare workforce in Nigeria. And I mentioned that there are healthcare workers without in-depth medical training, but who have contacts with patients as well. And some of them are the traditional birth attendants, the community health extension workers. This set of healthcare workers don't have extensive knowledge or medical training, and they have been found to have perceived low risk of getting contact with vaccine preventable diseases. So level of education is also one barrier to vaccination of healthcare workers in Nigeria. Now, vaccine schedule. Now, the current population of healthcare workers, using the statistics of doctors, which is put at the doctor to patient ratio, which is put as 1 to 22,000 in rural areas, 1 to 12,000 in urban cities. When we look at this implies that an average healthcare worker will probably be very busy or would not have time to actually get vaccinated, because this vaccine schedule, they are usually long, and for a busy healthcare worker, having to always remind themselves the need to take those vaccines. For example, hepatitis B vaccines, you take the first dose, from 4 weeks after, you take the second dose, and then you take the third dose as well. Now, it's difficult to follow up on this schedule for healthcare workers that are usually very busy. And this is a major barrier for vaccination of healthcare workers. Not to mention that some of these vaccines are not within the same facilities that these healthcare workers work in. They have to probably transport to a different area to get vaccinated. So this is a challenge. Now, vaccine.
Joshua, this is really interesting, I have to say, but I do need you to move a little bit more quickly because I see how many slides you still have to go.
Yeah. All right. So vaccine hesitancy is also another barrier, and cultural and religious beliefs and personal reasons are some of these issues that affect that. Now, insecurity, this is actually very important in for healthcare workers that are practicing in insurgent region, especially in the northern parts of Nigeria. Now, it's going to be very difficult for these healthcare workers to access these places to get vaccinated, and transporting of these vaccines to these insurgent regions would also be a problem, and this will constitute a major barrier for vaccination. Now, poor awareness about vaccine availability is also another barrier that has been recommended, as some healthcare workers actually don't know where to access these vaccines. Now, what are the best approach to scale up routine vaccination of healthcare workers in Nigeria? Now, there's a need for a clear written policy on vaccination of healthcare workers in Nigeria. And this clear written policy has to involve major stakeholders in the country. And some of these stakeholders involves the Minister of Health, the various Commissioner of Health in all the states, the Chief Medical Directors of government hospitals, as well as the leaders of private hospitals, where they come together and factor in the dynamics of the different healthcare settings available in the country. Now, healthcare workers' vaccination should be incorporated and made mandatory in pre-employment medical screening before they start working, since it's the practice that before you start working in a government facility, you are screened. And if this routine vaccination are included, it will go a long way in scaling up vaccination of healthcare workers. Then incorporating routine recommended vaccine of healthcare workers into the National Health Insurance Scheme, and making this recommended vaccine easier for healthcare workers to access. Then increasing the funding pool. Over time, Gavi has been a major funder of vaccination in Nigeria now, and World Bank also, but there's the need to leverage other partners, which would help reduce the cost of these vaccines for healthcare workers. Now, healthcare workers should be encouraged to get vaccinated by developing training initiatives on recommended vaccines and vaccination. And this would be something to consider at the local level in the setting of the hospitals. For example, private hospitals where the Chief Medical Director creates a platform to encourage vaccination of healthcare workers. Same goes for other sectors, other levels of healthcare setting in the country, where they create platform to encourage healthcare workers to get vaccinated. Also, the initiative must also factor in the training of healthcare workers on infection control and universal safety precaution, because these are also very key to put into consideration. Now, for healthcare workers living and practicing in insurgent regions of the country, incorporating vaccination into the camps set up for internally displaced people would offer a means of vaccine coverage to this target population of healthcare workers. In conclusion, the absence of a vaccination policy explicit for healthcare workers is a major obstacle for high vaccination coverage rate among healthcare workers in Nigeria. And then the gap in knowledge of risk perception for contracting vaccine preventable diseases is also high amongst healthcare workers in Nigeria. Thus, bridging this knowledge gap will improve vaccine uptake and significantly minimize this barrier and other barriers. Thank you very much for listening.
Thank you, Joshua, so much. You set out brilliantly what the problems were. And then what you've come back and done is said to us, okay, and here are some solutions. And I think that that's very helpful, not just in Nigeria, but will apply in other areas as well. And I think we'll have further discussion about that with our other two speakers. And that leads me on to, if you can clear your screen now, Joshua, and I'll introduce Professor Sharmeen Yasmeen. Um, Professor Yasmin is an experienced and renowned public health physician in Bangladesh, and she has been teaching and researching for 30 years. She's professor and head of the Department of Community Medicine in Bangladesh Medical College at Dhaka, and she's a founding member of the Public Health Foundation in Bangladesh, and she subsequently worked there as the CEO, the vice chairperson, and the chairperson. She's one of the public health professionals of Bangladesh who has experience of working on diversified public health issues and has relentlessly played a role to boost and motivate young professionals towards their professional competency. It is my great pleasure to introduce Professor Sharmeen Yasmin.
Okay, thank you, Professor Michael, for your nice and generous introduction. Good afternoon from Dhaka, Bangladesh to everyone. First of all, I would like to convey my thanks to the organizing team for inviting me here in today's webinar on this very important and time-demanding topic, especially when we are facing the aftermaths of COVID-19 pandemic. And in relation to today's topic, I would share with you my very personal and professional real-life experience, but will be a bit different from what Dr. Joshua has presented. But some of the issues would come up through my experience sharing. So now, first of all, if I want to share with you my personal story. In last century, in 1991, when about 31 years back, I was an intern doctor, and one evening when I was on duty in the gynae and obs department, a patient was admitted, and she was a full-time pregnant woman with preeclampsia and jaundice. And as a part of management, my colleagues were trying to start the induction of labor, and they are trying to insert IV cannula, but they failed. The woman was very much obese. Then they called me to try to insert the cannula, and I successfully could do it. And after a few hours, I conducted the normal delivery of that patient. And she was blessed with a healthy baby boy, but I was not blessed at that time, because after 1.5 months, I developed jaundice and I became a case of hepatitis B infection. And I was sent back to my home for full bed rest and also for treatment. And at the time, I was very much panicked and stressed to think about the complications of hepatitis B. What would happen if I become a carrier, or if I develop cirrhosis or liver cancer at my later age? And also psychologically, I was very much depressed to think about that. I would be lagging behind to develop my career for unlimited period. But fortunately, after 4 months, I became negative and joined my work. At that time, hepatitis B vaccine was not so popular and available, because you may know that being vaccinated by hepatitis B vaccine. And another professional experience I'd like to share is that from my long time experience in public health as a teacher, you know that in our EPI program, the women of reproductive age, they are the target population of tetanus toxoid vaccine. And more than 2/3 of our medical students are now female. So very often I ask my students whether they have vaccinated by TT or not, but most of them answer that they have not yet completed or they have not started. So there is very low uptake of vaccination, despite of having the TT vaccine at free of cost and administration of this vaccine at their own medical college hospital, the uptake was very low. And same thing happened in case of lady professionals who are working in our hospital. And so I will come to this context within few minutes, but before that, another experience from the COVID-19 pandemic, I would like to share that I was diagnosed as a case of COVID-19 in November 2020. And at that time, actually, my condition was not so critical, but it was a pandemic situation, and I saw many people around me are dying, who are my colleagues, and some of them are relatives. And also, we did not have any vaccine at that moment in our hand. So I was actually mentally ready to face the worst consequences. But I was only worried about my children actually, but none of them was infected, thank God. And within, after 3 months of my recovery, actually in Bangladesh, we started COVID vaccination. And then at that time, I did my antibody level. It was quite good. So I waited for another 3 months. Thing is that before administration of any vaccine, it is important to measure the antibody level to make the effective, to make the vaccine very effective. And also here, I want to say that in our national data, we don't have any figure how much of our healthcare professionals have vaccinated or under coverage of COVID-19 vaccine. But from an unofficial source, I have found that for dose 1 and 2, it was 95% and more than that in some cases. So it was quite good. And the third dose is still going on, or the booster dose. So the rate of uptake is quite good. It may be due to the pandemicity or due to high case fatality or severity of the disease. My concern is when there will be end of this pandemic situation, does this vaccination level would be sustainable like this? I don't think so. When it will become a routine vaccination program, the uptake will be low, like what happened in other cases. So if we are responsible, if we are smart, and if we are sensitive, we must not ignore and undermine the role of the vaccines for the vaccine preventable diseases for the healthcare professionals. Otherwise, we might invite another pandemic, resurgence of another pandemic in the coming days, which we do not expect. So my realization in this context is that we have not developed a legacy of culture of vaccination in our society yet. What Dr. Joshua said, exactly the same. We don't have that culture of vaccination. When it becomes a routine program, there is gap in the knowledge, there is gap in the attitude and practice, resulting in very low uptake of vaccination. And we also have observed vaccine hesitancy and also overconfidence due to herd immunity and misconception of self-limiting characteristics of the disease. And of course, there is financial issues. So my concern is to scale up the vaccination among the health professionals if we could implement the vaccination program for them. So measures are to be taken to minimize the gap in their knowledge, in their attitude. Of course, we have to minimize the gap in service utilization of the vaccines. We need to sensitize them, we need to aware them, and we need to empower our health professionals to actually guiding into action. So in our country, there is no statistics of how much, what is the actual disease load of the vaccine preventable diseases among the health professionals, and also what is the vaccine uptake rate among the health professionals. But there are some studies we have found that, especially I would like to mention 2 of my studies. I did it with my colleagues in a tertiary hospital, where we found that the level of vaccination of tetanus hepatitis B vaccine among the nurses and lab technologists. And we found that 34% of the nurses vaccinated by hepatitis B vaccine, and 50% of the technicians were vaccinated, and none of them did the antibody level before administration of the vaccine, which might pose the ineffectiveness of the vaccine. So it is very important. And we conducted another study with my team to assess the tetanus toxoid vaccination among the nurses of a tertiary hospital. And we found that the vaccination level with the complete doses were 49%, and 43% had incomplete dose, and 8% did not take any TT vaccine. So it was almost similar or a little bit higher than what Dr. Joshua said in his presentation. So, and also we have had some studies on the medical students as well regarding the hepatitis B vaccination coverage. So it was found that it was 41.4% among the medical students. It was a cross-sectional study, and in another study, it was found that the hepatitis B vaccination rate is 66%. So in a nutshell, in our country, culturally and conventionally, we are not very serious to protect ourselves by available vaccines. And healthcare workers vaccinated by their own cost or by their own interest, but except the COVID-19 vaccine. And very few are vaccinated by their institutional initiative in our country. So we have enough scope to continue further research at the national level and institutional level to develop evidence and for advocacy. Now, regarding the EPI program, I would like to say that it is very much successful EPI program for the children in our country. We have a good coverage of EPI, and after 8 years of our independence, we started EPI program in our country in 1979 with 6 vaccine preventable diseases for the children. And it was expanded in 1985, both in rural and urban area. And gradually we successfully could introduce some other vaccines. And now we are in our schedule 12 vaccine preventable diseases for the children. And because for children, the program is very successful. You know, we are very much sensitive about our children, and we have a very inbuilt system of for vaccination program in our healthcare delivery system. And a political commitment, I would like to mention here that it was politically, our leaders was very much convinced to implement the targets of EPI in reducing the mortality and morbidity among the infants. And you'll be, I am very glad to share with you that in MDG, you know that in the number 4 goal was improvement of child health. And in this goal, our government received, our Honorable Prime Minister received award for achieving the goal long before the stipulated time in 2010. So it's another achievement for our EPI program. And during the pandemic period, we have seen that more than 200 health professionals we have lost, and most of them are doctors. And if we add the other categories of health care professionals, the number would be bigger. And within this year, what we have seen that after initiation of the vaccination program, though the mortality and morbidity and disability due to COVID-19 have greatly reduced, but we have seen that many professionals died at very young age, from 40 to 50 years, because of massive heart attack or stroke. It may be due to the post-COVID complications, which is yet to be explored actually. So, and you know, thing is that we could reduce the mortality and morbidity and disability due to COVID vaccination, and also we could increase the recovery rates. And you know, there are other vaccine preventable diseases, and there are other vaccines also, and these need to be incorporated in our vaccination program. So I think during the early part of COVID-19, we have seen that even in the developed countries, many of the health professionals and patients died due to nosocomial infection, especially the patients died due to nosocomial infection. And some of the COVID patients also died due to infection that was contracted from the duty doctors. So I think this vaccination program will greatly reduce the nosocomial infection and also the death rate among the health professionals. And one thing is important, that there are other vaccines to incorporate in our program. Most importantly, I would like to mention 4 vaccines. These are hepatitis B vaccine, influenza vaccine, pneumococcal vaccine, tetanus toxin, and another one is meningococcal vaccine. These are very important. And studies showed that there is association between increased influenza vaccination among the healthcare workers and decreased nosocomial infection. And in a meta-analysis, it was seen that in a reported influenza outbreak, the attack rate of influenza was higher among the healthcare professionals. It was 24%, 18% to 24%, and in general population, it was 11%. Again, according to WHO, it was stated that the 54% of the health workers in low-income country and the LMICs, they are 25 times higher at risk of developing infection than the general population. So I think all the vaccines, including the COVID vaccine, will protect our health professionals to get rid of this dreadful infection. They will protect their families, their colleagues, and the patients. It will increase their life expectancy and promote health and efficiency, and also prevent sickness absenteeism and prevent financial loss and improve the economic growth. So regarding the barriers, what Dr. Joshua said, it is almost similar like in our country as well, because we have seen that there is fund shortage also. Though we have a very good API, we actually get help from the external funders. So it is one of the challenge if we want to incorporate the other vaccines for the healthcare professionals. And we have a lack of baseline data. That is another challenge for us. Poor cultural practice, then myths, limited knowledge about vaccine safety. These are important. Limited resource for supply and operation and manpower and logistics, and issue of equity and social justice. This is very important, and we have to establish equity and social justice through different our strategy in our national programs, of course. And regulatory policy and immunization schedule maintenance is another challenge for us. And also key players must be involved, convincing the key players, motivating the key players through proper advocacy. This is another challenge, and I am thankful to you that you have raised this issue, because in LIC and LMICs, it is very important. We have not yet addressed this issue. Actually, it is at the bottom part of our priority list. For you, we are raising our voice. So I think it is important for all the professional bodies, not only the Public Health Association or something like that, also other multidisciplinary bodies, student bodies, to come forward and raise their voice to endorse this agenda in the coming days to save healthcare professionals not only, and also to establish a balance of right, to establish social justice and equity. So with that, I would like to stop. If we have time, we can talk in next round. Thank you.
Thank you so much, Charmaine. Yes, we will discuss some of these in a short while. But what we appreciated was, first of all, you sharing the personal experience, because sometimes that personal anecdote really brings home the reality for people of what we're dealing with, and the importance, therefore, as you explained in statistics and evidence, of the importance of then ensuring that our healthcare workers are vaccinated. There were 2 other elements that I thought were really important that you raised. One was political will and political commitment, and you mentioned that with regard to the expanded program of immunisation from the World Health Organization, you referred to as EPI, and of course advocacy, and that is one of the things that goes hand in hand with political commitment. So thank you very much, and we'll come back to a few questions around those areas. But now it's my pleasure to move to Dr. Dominic Konji, who I can also introduce as Chief Dominic Konji, who's a Senior Public Health Communication for Development expert. He's a graduate of the University Centre for Health Sciences at the University of Yaoundé in Cameroon, and he holds postgraduate diploma in public health of the Regional Intercountry Higher School of Public Health in Central Africa, which is based in Brazzaville in Congo Republic. He's a founding member and president of the Cameroon Public Health Association, a member of the executive committee of the African Federation of Public Health Associations, and in that capacity, he also looks after policy and programs. Chief Dominic Konji is a regional councillor for the Littoral region, representing traditional chieftaincy. It's my pleasure to now invite Dr. Dominic Konji to present.
Thank you, Michael, for your kind introduction, and also thank you for adding me in this panel, talking about health workers organization in the world. Particularly, I'll talk about Cameroon. Mary, can I have my slides, please? Okay, if not ready, I'll start by saying that it's since 1976 that the government of Cameroon, with the support of WHO, has put in place an expanded program on immunization. And this program targets mainly children under 5 and pregnant women. This is the targets, the main targets of this program. Okay, now health professionals are not yet the population for routine immunization in this program. They are occasionally vaccinated when a disease emerges, like a COVID-19 outbreak. So this is what I can say first for what concerns Cameroon. Slide, please. Now we see the decision to consider health professionals are prime targets for routine immunization, such as children and pregnant women, is political. We think it's political because it's the ministry, the government, that has to take this decision. It's therefore necessary to carry out advocacy with national authorities for this purpose. We consider that this vaccination should be free of charge, like that of children and pregnant women. Slide, please. But it's good to know that in the past, students in health professional schools were systematically vaccinated. I remember when I was a student, we were vaccinated. But when you come out from the school, you are not followed up in terms of vaccination. And we think advocacy is definitely necessary to decide on health professionals to be systematic, to have systematic vaccination. The national vaccination policy documents, as well as the norms and standards of the vaccination program, must be modified. Because in Cameroon, for instance, we have what we call norms and standards, and then we have a policy, immunization policy that is adopted by the government. And to make sure health professionals are targets of systematic or routine immunization, all these documents have to be revised and this taken into consideration. Slide, please. Now, we know that vaccines have a high cost that some countries cannot fully afford. But let me say that in Cameroon, the government co-finances vaccine supply with the support of Gavi. With COVID-19 and the COVAX program that targets health professionals and aging people with comorbidity, this could be an opportunity to decide to protect health professionals systematically by immunization. We think that we can take advantage of this COVAX program that is targeting health professionals and aging people to make sure other antigens are involved in this, and so that health professionals are vaccinated. Slide, please. A combined action of information, advocacy, and education of health professionals and professional organization, council is needed to convince the government. We think that this should not be an action that comes from abroad only. At national level, professional associations, professional council of medical doctors, nurses, and all these must be aware of this situation and take it for their case so that they start advocating for immunization, systematic immunization. Now, a systematic approach is needed when fighting preventable disease by vaccination. I will say, for instance, vaccination brings together several technical and scientific groups in the world. As an example is such, for instance. We need all these bodies, international, national, regional, to come together to advocate so that countries adopt this vaccination systematically for health professionals. Slide, please. Now, we want to conclude. We'll have to discuss after that. In Cameroon, the infrastructure for immunization exists. They need just to advocate for a political decision to consider systematic vaccination for health professionals as part of occupational safety program for them. And we conclude on saying that if we protect health professionals with immunization, in fact, we protect the whole population. Thank you very much. I hope we'll have questions and answers. Thank you very much.
Thank you very much, Chief Dominic Konji. And let me remind people that you can put questions in the Q&A should you so wish. But what Dominique has done is picked up from what our other two speakers have raised with us and actually put it, if I can put it, a sharper edge on it, where he has talked then about the importance of the political and in advocacy, but most important of a systematic approach. And I think that's something that we will come back to. Just before I start the discussion, I'm going to ask for a slide to be put on the screen while I thank those people who have supported us. So particular thanks go to the World Federation of Public Health Associations, but also our support from the University of Geneva, the Faculty of Medicine and the Institute of Global Health, and Pfizer Pharmaceuticals, who have been brilliant at supporting our efforts on such webinars and on this webinar in particular. So thank you to all of those. I'll move to my first question, because I want to go back to a question of clarification with Joshua. Joshua, in one of your slides, you said that healthcare workers are a demography that's known for worst health-seeking behaviour. Are you talking about their own behaviour or encouraging others for health-seeking behaviours? Because that's a really interesting insight.
Yeah, I was making reference to the healthcare workers' behavior in seeking healthcare. According to a study done by Omulewe, it was actually the one that found this out, and it showed a very significant finding that there's actually a poor health-seeking behavior amongst healthcare workers in Nigeria, and that's really
ironic. It's ironic, isn't it?
Yeah, it is. It is. Yeah.
Charmaine, have you found a similar finding, or do you have a similar sense of the same thing in Bangladesh? Because if so, there's something that we really need to tackle.
Yeah, actually, same kind of impression I found, because if we see at the levels of vaccination in different studies that I have mentioned, it is one of the outcome of the health-seeking behavior of our health professionals. Yes. So it is very much true, actually. And, you know, there is a cultural gap I think there is no monitoring as it is not within our national policy level, yet it is not yet included. So there is no pressure on our health professionals to continue with their vaccination process. So it means what you have said, a systematic approach, what Dr. Dominic has said, it is very important. Unless we do not demand for our own need, the policy level people will not do anything. So I think it is very important. So this cultural gap of seeking behavior, health seeking behavior, it is existent, I think, all LIC and LMICs. If we look into the different studies, we'll see. So I to work in this area to actually build up the knowledge, and also it policy regulatory approach is very important, from the institution or for the government level. If we have any surveillance system for every institution, how many of our health professionals are vaccinated against the vaccine preventable diseases, if we can develop inbuilt mechanism within our system, I think they will be more aware. Even the employers will be more aware of that. So they will be institutionalize this mandate for their workers' safety. Thank you.
And Dominic, did you want to make a comment on this, or will you build into further comments?
Yes, I have the same comment. It's the same thing. I think health professionals should be the first to demand protection through immunization. You see, as I said, for instance, in our country, in school, when they enter schools many years back, there was vaccination. But now it's the schools that were vaccinated. But after that, the professionals don't seek for immunization. They don't seek for immunization. And they should be at the forefront to demand vaccination. So I think this is very, very important. We have to emphasize on the fact that we should make sure health professionals seek better health behaviors.
So our advocacy should be both going to government, but also going to healthcare workers, and sort of a dual direction advocacy that will, which actually will probably have more impact. So the first question that I see comes from Georgia Mofa, who I recognise. In most cases, he says vaccine hesitancy also affects healthcare workers. What are your experiences in this area, and how are you proposing to address the problem? Charmaine, can I start with you on hesitancy?
Okay, actually, it's still the figure is unknown to us. What is the exact vaccination rate or the actual disease load of the vaccine preventable diseases among our healthcare workers? But you see, we very often see that in the after the age of 60 years, many of the health professionals who are aged, they die due to chest complications, due to pneumonia or influenza, like this. So I think we have to just not at a bigger aspect, we first move on, but we can actually we can cater the vaccines which are really essential for us right at this moment. So I think regulatory approach is one thing, and also institutional mandate, this is another thing. And here in our country, you see the evidence-based information, there is lack of evidence-based, lots of researches must be going on, this is one thing. And community mobilization, what actually other speakers also said, that community mobilization at all level, from starting not only the doctors, although the other healthcare professionals who are going to every house, the health workers in our grassroots level, they're also very important, and they are very much exposed to this infection, apart from our hospital who are working in the hospital. And during the COVID pandemic, we have seen that those who work in the critical care unit, in ICU or CCU, the mortality rate of health professionals in those areas was very high in comparison to other sectors. So we have to prioritize which of the sectors would be given first attention for implementing this vaccination. So there are different issues in the policy level. I think in course of time, they will think of it. And I am hopeful about our country. Thank you.
And I think that goes back to Joshua's original point about the importance of having written policies in this area that identifies specifically what you need to do and when these should go. And I particularly like, Charmaine, that you gave specific examples of influenza, pneumococcal, varicella, vaccines that are for older people, vaccines that are about all of life rather than just to focus on children. The written policy, Joshua, I presume you see it, we know you see it as important for Nigeria, but do you see the nuance that Professor Yasmin is bringing out here?
Yeah, I think I kind of share our idea about what she mentioned. The written policy, very important, and there's also the need to incorporate, in my earlier discussion, presentation, I made mention of incorporating major stakeholders, because it's not just to write the policy, it's important to also factor in the dynamics of the different health care settings that we have in the country, and that way a policy that is robust, that is encompassing, would be made if major key stakeholders are involved. And in the case of Nigeria, that would include the commissioner, the Minister of Health at the federal level, the Commissioner of Health in all the states, as well as the chief medical directors in each of the government hospitals, as well as the medical directors in private hospitals and their association as well. This is
the systemic and systematic
exactly
systems that Dominique is talking about that are important in Cameroon, but I think we've all agreed they are really important right across all low and middle income countries. Can I go to the next question? Come from Ronan Vadakantos, and he asked about the financial burden of immunisation, and who do each of you think in your countries and more broadly, if you like, is responsible for health workers, both their antigen level testing and also their immunisations? And can I start with you, Dominique, on that question of the financing?
Yes, Michael, I think vaccines have a cost. And, in our countries, Gary, who is the main, let's say, support of our countries for immunization, has introduced the notion of co-financing. Countries should co-finance vaccination programs to vaccine or have vaccines. And I think in my country, for instance, we've reached a situation where the country is in its budget has to buy for vaccines. So I think the main action to do is to make sure the government accepts to vaccinate health professionals. If this political decision is taken, means will follow, resources will follow. So I think in Cameroon, since the government co-financing vaccination in general for under 5 children and pregnant women, and now they are planning with Gavi and COVAX to vaccinate systematically health professionals for COVID-19. It means if we advocate well, they will we can use other antigens to be part of immunization. So I think that's why we can do advocacy for resource mobilization so that vaccines are available.
And for you, Charmaine?
Yes, what Dr. Dominic has said, I just echoing with his words. And in addition, I would like to say that after political acceptance of this agenda, eventually, actually, each country must develop that capacity to manufacture this vaccine within their country, because how long will depend to improve our self-reliance and reduce dependency on the external funders. Because pharmaceutical, in our country, pharmaceutical industry is very much good. We are exporting drugs to other foreign countries, and some of the vaccines are being produced in our country as well.
Indeed.
I think we have, we will be able to develop that capacity to manufacture vaccines in future. We have to keep it in mind for every country. Thank you.
Did you wish to comment, Joshua, as well?
Well, I share similar view with Professor Sherman. So because these funding from external sources are not going to be there forever. I mean, there's the need for us to find a way within our country to also try to do this thing ourselves. So looking for in-country funders, you know, or other alternative source of vaccination funding will be something to consider. In the case of Nigeria, possibly taxation on some industrial telecommunication industries, and this money could be channeled into the vaccination scheme, would be something to consider. Other sources.
I think we would all agree, however, this would take a careful transition period. The worst thing would be, okay, now you've got that responsibility, and we've seen that happen in other areas. So it is a bigger challenge for low and middle income countries. I'll take us to a question from Adite Makaringa. I hope I pronounced the name reasonably. Who's concerned about the inconsistency and lack of evidence in the schedules, particularly for new drugs such as COVID-19 and for the new vaccines, and feeling that does this bring about a bit more hesitancy, because this was a vaccine that was developed very quickly, and different countries have had different schedules. I wonder if I can start with you, Joshua. How do you respond to that question?
Well, I think it's possible that this might be a major factor to that might bring about vaccine hesitancy. I mean, having knowledge of something is very important. If I'm going to involve myself in something, I need to know what I'm getting myself involved in. So being knowledgeable or being aware of this vaccine, what it is, would really be something that might help vaccine uptake. Now, in Nigeria, where a lot of people are really very cultural and traditional, and then they tend to associate some things with some myth. So it's possible that there might be some vaccine hesitancy with this inconsistency with different vaccines that are being developed. So that's my take on that.
I'm just going to take that a little bit further, and then I'll go to others. But when you're talking about the traditional and cultural things, and because that applies in each country, how important, therefore, is it to get religious community leaders, chieftains, on side to ensure that they understand, first and foremost, what's happening, and how important is their leadership, if you like, in advocacy terms?
It is really very important, especially in the Nigerian setting. I recall back then in medical school, when there's this particular posting we go for in public health, you have to seek the community, it's called community entry, where you actually go to meet the community leaders and introduce, let them know that you are here and this is what you want to do in their town. And then they give you all the support that you need. They tend to guide you, make you understand the dynamics of the environment. So it's really very important that community leaders are involved in whatever advocacy plan we will be making. So it's really very key in the Nigerian setting.
Thanks. Dominic, did you want to add to this response?
Well, I wanted to add that, yes, the fact that the manufacturing of this COVID-19 vaccine was very rapid. It was very rapid. And then there was a sort of confusion among scientists. Scientists were not saying the same thing about this vaccine. And you have some group of scientists that were reluctant, and if scientists are reluctant, if they don't agree on something, now this is a way for vaccine hesitancy. Now, there is another point that I want to raise. It's the top-down approach that our government use to impose immunization. I think it's not a good, I've already written, I've already done the research on it and share it with the government. Even if a decision is taken at government level, there is a need to go and advocate, go and do social mobilization, go and work with many stakeholders to tell them this is a necessity, we need this because, and then we want you to adopt it and together with the government to convince the population. So this top-down approach is not good. We need to use sometime, even if decisions are taken at central level, to go down to the community level, convince people there, and then come up. This is, I think, we can share on it. Thank you.
Yeah. And did you want to add to that, Charmaine?
Yeah, that is the fact that our local leaders, the religious leaders in our country, they can convince people. Even our doctors or health professionals fail sometimes to convince them, but our religious leaders, they actually do that desirable thing to happen. And one thing that he was asking about the dose schedule of the vaccines in different countries. So in relation to that, actually, the dose that has been decided by after having evidence-based research and different kinds of antibody level and formation of this antibody level and sustainability of these antibody levels actually varies from nation to nation. And so I think that in a study, it was found in our country that it was conducted by ICDDRB and IEDCR. They found that in the early part, the slum dwellers in our country and people who are in the low socioeconomic status, they found antibody level against this antigen in their blood. So actually, it varies from country to country, their genetic acceptance and like this. So that is how it differs actually. And another thing is that in our country, just our government has announced for registering the 4th schedule of the vaccine. So, but in developed countries, I know already the 4th schedule, 4th dose of the COVID vaccine already you have started. So there are some differences. And this is another thing, just in relation, not related to this, but I would like to mention because I might forget, that is the interministerial coordination is very important. Interministerial coordination is very important because in our country, urban health program that is controlled by the LGRD ministry. LGRD ministry, they are controlling the urban through many city corporations. They are providing healthcare. So I think interministerial coordination is very important to implement and execute all these policies also. Thank you.
What an interesting thought, and as soon as you said it, just made sense, and I presume made sense for others as well, because it's very rarely one part of government that does the whole process. One might decide, yes, it's important, but then implementation can often be in the hands of others as well. I will just comment that Ronan, who answered one of his questions before, has also asked, but should health professionals do the testing and immunisation as per correct recommendations, and how often should this happen? Well, I would just say, of course, against the recommendations, but every vaccine is different in terms, and we have to, that's why we have the schedules. That's why we look at the schedules to see how regularly people need to be vaccinated, and make sure that we work according to the schedules. But even more, another really interesting question comes from a nurse who works on clinical trials, and that's Leila Magor. Once again, I hope I pronounced the name reasonably well, and who says actually she's still hesitant to get vaccinated because what she has, even though she knows the vaccine is useful, she has seen adverse events. And is there any mechanism in place to have people reporting adverse events in your countries? So I might start there with you, Professor Yasmin, and how you would answer this and encourage the nurse to have her vaccinations, which is what this webinar is about. But thank you for your courageous question.
Regarding the adverse effect, we have a reporting system in EPI as well as in the COVID vaccination procedure. So it was actually a practice from the very beginning of the EPI, adverse effect reporting. So I think not so much adverse effect we actually found within the people who were vaccinated. So people in the beginning, they had some hesitancy due to the adversity of the vaccines. But in course of time, when they got the authentic information from the reliable sources, also assurance from the political leader and then health leaders and also from the local leaders. And they have watched that everybody is vaccinating and they are well, and there nothing such complications occurred due to vaccination. I think reporting system is there, but nothing serious was found, both in the COVID vaccination, also in the EPI process in our country.
And what about you, Dominic?
Well, I think health professionals, health workers are not so different from the rest of the population. The difference is the fact that they've been in schools and they have learned medical techniques and all this. But they are as the other population. And this issue of adverse effect events following immunization is a big problem with the immunization program. But I think what we need to do is to make sure health professionals have the good information, because you usually think that because they are trained in some techniques in health, in medicine, that they will accept and promote vaccination. This is not true. They have their beliefs before the training. And sometimes even after training, the beliefs, cultural beliefs are there. First thing. Second thing is social media. When social media diffuse information against immunization and diffuse all these side effects and all the, when health professionals are not well informed, regularly informed on what goes on and what to do, they also are candidates for hesitancy. So I think we need to do a lot with health professionals in terms of informing them, in terms of in-service training on immunization, and to understand that, yes, there are adverse events, but they are not so much.
Yeah. And Joshua?
So in Nigeria incorporated the adverse events following immunization surveillance with the expanded program for immunization. However, that said, it's because it's a mix. Usually, there's the active and passive surveillance, which involves either healthcare workers reporting any adverse effects they've observed, or the general public coming forward to state. And this is not always effective, because because of this mixed practice. So, I think a lot still needs to be done with this surveillance system of reporting adverse effects. But this, like Professor Sharmin mentioned, this system is on ground, but the question is how well is this surveillance? How is it done, and how well is it utilized?
Thanks to you all. I'd like to just make a comment actually about a developed country, the one I live in Australia, and where we actually have very good reporting systems of adverse events. But even with very good systems, no system is perfect. And there's still a human element about what is reported and how it's reported. However, taking that into account, the risks associated with adverse events are tiny compared to the risks associated with a disease against which we're vaccinating. And I think that's the really important principle that you have to remember. And I know because I've also seen individuals who've had adverse reaction. And when you've seen an individual, your reaction is strong. However, if you can look at the epidemiology, if you can look at the statistics there, and keep in mind that if you're also looking at people with the disease, it's much worse. And so and I think that's a really important factor. We've focused quite a little bit on hesitancy, and I see we've got another couple of questions, but I do want to just touch on social justice, because each of you talked about social justice and the role that vaccines play in social justice terms within your community. I wonder, Dominic, if I can start with you, because you, well, you all mentioned this.
I think talking about social justice, the first thing for us in our government is to make sure people know that vaccination for children, vaccination for health professionals is a right. Is the first thing. And I think it's not what is done. It's not understood like that in many countries, and particularly in my country. People don't know that vaccination is a right, the right to health, the right to vaccination. So we need to inform, educate the population, educate health professionals that immunization is a right and they need to demand immunization. When people are well informed, they have understood, they will demand, they will start demanding immunization, vaccination. And so I emphasize on the fact that we need to educate the population on the fact that health is a right, immunization is a right. And when people will know that, they will accept vaccination and they will demand vaccination.
Yeah. Did you want to add anything to that, Joshua or Yasmin?
Well, I think I share the same view with Dr. Dominic, especially in communities where healthcare workers are facing insurgency. I think it is very important that this group of people, there's the need to get this group of healthcare workers to be vaccinated, you know, as much as possible. So in a bid to mitigate inequities in vaccination of healthcare workers in Nigeria. So these areas need to be considered alongside what Dr. Dominic mentioned.
Yeah. Charmaine, did you have anything to add to that?
Regarding the equity and social justice, actually,
yeah.
like to say that, as Dr. Dominic has said, it is the right. So it is the right of the patients not to be contracted by with any infection from the healthcare professionals. Also, it is the right of the healthcare professionals not being contracted by any infection from the patient. So it is
ways.
Yes.
Yeah.
Number one. Number two is we have to remember about the principles of health ethics. One is the right, and then is the beneficence and non-malfeasance. So if we keep it in our mind, these three principles of health ethics, I think it will be easier for us to establish equity and social justice. That's what I wanted to mention. Thank you.
The next questions are also interesting around hesitancy, and it comes from Haile Kasahan from Ethiopia, and who just raised the issue that he was hearing that some people say that the vaccine had killed, that there were blood clots, that there were other things that occurred, but there was never a really clear picture presented by the authorities on this. I must say there was some confusion early with regard to the vaccine, but what we did hear is my understanding is that most of these cases were taken out of proportion. Blood clots was an interesting one and needed to be taken into account and care taken. What's your reaction to the issue of vaccines being challenged on these grounds?
I don't think we had any record of blood clots, although, I mean, I'm aware that in the initial phase when the vaccine was released, there were speculations and there were record of cases of blood clots in other countries, but there was nothing like that in Nigeria, to the best of my knowledge. So,
yeah. Look, I think that actually answers for all of us. We're coming towards the end of our webinar, and so I'd just like to give you each the opportunity to follow up with a concluding comment before I mention something about the World Congress on Public Health, and before I thank our participants. Can I start with you, Dominic?
Well, I'm very glad to have been part of this webinar, and I'm also very glad to know that we have many people that are following this webinar. I think all what we've discussed here is very important, and let us take it as a message that we have all to invest in advocacy at global level, at regional level, at country level, even inside countries, to advocate for immunization in favor of health workers in general. And I want to add something concerning this vaccine existence by saying that, you know, when a decision is taken at global level to vaccinate, it's a case of COVID-19. The decision to vaccinate is taken at global level, and this becomes at regional level and country level. Now, the decision is taken, but you know, people are hesitant and they say maybe our government is not convinced, but they are doing because they receive needs, they receive resources. So you have this information that is diffused, and if the government doesn't explain well to the population to understand and make sure all stakeholders understand, in fact, it goes bad. So there is something to do also with the government to make sure they own what is decided internationally, globally, and then make sure at country level, people, all stakeholders understand and be part of the process to promote vaccination. Thank you.
Thanks, Dominic. To you, Joshua.
It's a great opportunity once again to be able to share the Nigerian perspective on this very important topic. And just to mention, part of the systemic approach that must be kept in mind is the incorporation of students in training, which is very, very important. Yeah. Medical students in training, nursing students in training, and other students in the other allied health profession that constitutes or that would constitute the future healthcare workforce. It's very important that they are we catch them young. Let me use that word, and we are able to make them have that perception of the risk of vaccine preventable diseases as healthcare workers, and they are aware of the need to get this vaccine.
That's and I hope, Joshua, written into your written policy.
Exactly.
To make it systematic. Yeah. Exactly. Yeah. Thank you for that very much. And Charmaine Yasmin.
So just one thing I would like to say in the last, that in our medical education curriculum, under the occupational safety, the vaccination of the healthcare professionals should be greatly emphasized, so that from the very beginning of their career, when they are students, especially who are in their foundation education, they will be aware of this importance of this vaccination. So in the long run, we will be benefited. And networking and experience sharing is also very important. And I think the international organizations like WHO, CDC, World Federation of Public Health Association, and they already, WHO has recommended and CDC has recommended some vaccine, but it is not possible in every country's context to vaccinate by all the vaccines. So in our country context, feasibility should be assessed and cost effectiveness should be assessed. And you know, in our country, the out-of-pocket expenditure is very high. It is about 68%. And eventually, if we can promote this vaccination at all levels, especially the healthcare workers, it will indirectly minimize the cost of this out-of-pocket expenditure as well. So we need to actually do more evidence-based research for moving forward with this agenda. And we should endorse all the low-income countries and middle-income countries at the political level. They should sit and they should endorse this agenda for all countries. Then I think at the national level, they can start working on it, and eventually involving all the stakeholders. These are also very important. That's what I wanted to add.
Thank you, Professor Charmaine Yasmin. Thank you, Dr. Chief Dominic Konji and Dr. Joshua Igbenamami. Your participation has been really appreciated. I'd like to go to the final slide, and as we're going to that slide, I'd like to acknowledge once again the University of Geneva, the World Federation of Public Health Associations, and Pfizer. Many of you will be aware that the World Congress on Public Health is being held in May from the 2nd to the 6th in Rome. And you would also be aware that that the opportunity to put in abstracts and to have early bird registration was due to close tomorrow. And the good news is that the World Federation has now extended the deadline and is now to December the 15th instead of December the 9th. So you have a bit more opportunity to get an abstract into the World Congress, and you also have an opportunity to register. So thank you, everybody, and thank you not only to those people who are here on this webinar on Zoom, but those who are also following on Facebook. So thanks, everybody, and I now declare this webinar closed.